Great. Thank you, everyone, for joining us today. I'm Dr. Sharon Milgram, the Director of the Office of Intramural Training and Education at the National Institutes of Health. And this is the first webinar of a series that will go on all year, focused on the mental health and well-being of biomedical researchers. We've been having discussions with trainees about health and wellness. We've offered trainings for administrators and faculty about supporting the mental health and wellness of trainees. And I realized as all of this was developing this year, and as I think about the difficulty of the last 7 or 8 months and the concerns that we have for the wellness of our community moving forward, that it was really time to have some dialogue and discussion together. So in this series, we've invited trainees and students, staff, faculty, administrators from universities and from NIH, with the hope that all of us talking about these important topics together will help us navigate the difficult times ahead, and also hopefully lead to some culture change in the long term. I think many of us agree that we would like a different culture in science, one that puts the health and well-being of the scientific enterprise at the forefront. And so here is a list of the topics. This is tentative. I think that we are still working out the details here. All of these monthly programs will include a talk followed by some Q&A, and then a chance for participants to mix together in breakout rooms. There'll be a facilitated discussion in each of them, a chance to process the material, to ask questions, to talk more, to learn from each other. And those will be a mix of all the different participants, with the hope that as trainees and staff and faculty begin to talk about this together, we will all find ways forward to support each other. So this week's webinar, this month's webinar, I guess I should say, is on suicide awareness and prevention. And it comes out of a training we did this summer where many people in the feedback said that it really was an important topic, a difficult topic, and a topic that we needed to talk more about. So I'm pleased to introduce Marin Rieger, who is a psychotherapist at Jonah Green and Associates. She has been working for 15+ years on the clinical side and also doing research work on depression and suicide. She's been a research coordinator at Johns Hopkins. She has a private practice, and she serves as an OITE wellness advisor. And so Marin is going to take us through the material today. And then at the end, I will, if we have time, moderate some Q&A with Marin, and then we'll give you instructions for joining us in the groups. Thank you all very much for being here.
Hi, everyone, and thanks so much, Sharon. As she said, my name is Marin Rieger. I'm a psychotherapist in the area, and I work with NIH as a wellness advisor. And I'm here today to talk about suicide, particularly in the biomedical research community. But I think, you know, it's really an important topic for the world at large right now, considering what we're going through. I work with professionals in the scientific research community, and I work with other patients who are struggling with suicidal ideation. Every week I talk to people who have thought about or attempted suicide. And so I'm passionate about the topic, and I really want everybody to know that you can make a difference in this topic, whether you are a health professional or not. So let's get started. I want to start with a quote that is from the suicide prevention website. It says, "You don't need to be a doctor or a psychologist or a therapist to say the right words to someone. It can literally be one word, one sentence, and it just clicks." I love this quote because it's kind of the take-home message that I'm really hoping people gain from today. It's that, you know, in an ideal world, we wouldn't have to talk about this outside of mental health professionals, but we can't really afford to have this conversation just be limited to therapists and psychologists and psychiatrists right now, because we found that anyone really can help reduce the number of suicides by just talking with colleagues, members of your community, talking about the topic, the difficult, uncomfortable topic of suicide. So what I'm hoping you're going to come away with today is, number one, just kind of a better understanding of the scope of this problem. And then we're going to talk a lot about how to ask this scary question of, are you thinking of killing yourself? Are you thinking of committing suicide? Because we find if we just open up the conversations, we can reduce the numbers. So we're going to talk about how you can feel a little more comfortable asking that question to colleagues. And then what do you do if they say yes? And how do you determine the best course of action for you and for them? So the topic of suicide, of course, is defined as death caused by self-directed injurious behavior. Suicide attempt is non-fatal, self-directed, potentially injurious behavior. And then we have this topic, this concept of suicidal ideation, which can be kind of vague and unclear, but it means thinking about, considering, or planning suicide. It can really exist on a spectrum of low risk to high risk, and that's something we'll talk about today, but you should know that thinking about killing yourself does not necessarily mean that a person is going to make an attempt, complete suicide, or even move into any planning stages. A lot of people who are struggling with depression or major life circumstances have thought about killing themselves. It's a different subset of that group that then goes on to make an attempt. So that's an important thing to consider. Why should we be talking about this today? It's actually a really major public health concern. Suicide in many populations is on the rise. Over the past 20 years we've seen a steady increase. We've seen more of an increase since COVID, although we're just starting to understand sort of the long-term mental health consequences of COVID. I feel very concerned that the numbers will go up because of what our culture is experiencing right now and all the struggles. It's also something really important to talk about because it's such a devastating impact on a community and a family. The trauma, distress, and grief involved in suicide is really complex and widespread when someone commits suicide. There's still a ton of stigma attached. There can still be a lot of shame, a lot of guilt, a lot of confusion. And it's just really impactful and really important that we talk about it and help normalize a little bit just the discussion of this problem. The numbers are huge. Somewhere between 800,000 and 1 million people are estimated to die from suicide each year across the world. And we really do see suicide rates all over the world. In the US, in most recent statistics, suicide was the 10th leading cause of death overall in the US. Kills about 50,000 people a year in the US is the numbers we normally see. So again, why is this particularly relevant to this group and this population of healthcare and science professionals? Because suicide was the leading cause of death among individuals between the ages of 10 and 34, and the 4th leading cause of death among individuals between the ages of 35 and 54. So you're really looking at these young adult and adult populations who are in the workforce who are seeing higher and higher numbers of suicide. So as I said, the data shows us that suicide rates have been steadily increasing over the last 2 decades, and the numbers only continue to rise. So it's really essential that we talk about it. I want to make sure that we focus on one of the key points here today. One of the main takeaways I hope you get is that research shows us time and again that even brief interventions conducted by a single individual can be effective in lowering suicide rates. So if you feel right now that you couldn't possibly make an impact on this issue, you probably can. When we talk about brief interventions in research, like I said, that doesn't necessarily mean an intervention by a mental health professional. That means that a single conversation with a trusted colleague or a trusted individual in someone's life where they talk about suicide can be effective in lowering rates. So thinking thinking about suicide and COVID, like I said, we don't know exactly yet, with the research, what kind of an impact, of course, this will have on our mental health. But we know that because of COVID and all of the devastating impacts, our mental health system is really overburdened. I mean, there's been so much focus on how much our medical systems have been burdened, of course, right? But the mental health systems are burdened as well, which makes it all the more important that we all become a little bit more comfortable talking about suicide. So what we know about a lot of what contributes to suicide overlaps with what we know about COVID-19, right? We know that there's extreme career stress for a lot of people. A lot of people in the research and healthcare communities have had extreme career stress throughout this time and will continue to. Social isolation, that is a really important part of suicidal ideation. Isolation is a real risk factor. And right now, people are oftentimes more isolated than ever, and they're isolated out of a public health concern for their health. That isolation can have a really negative impact on mental health. It can also make it harder to gain mental health resources within their community, not only because the system is burdened, but because it's just harder to get to those resources. We know that's oftentimes particularly true for people of color. It's hard enough for them generally to have access to proper mental health support. It might be even more difficult now. And then of course, just the physical toll of the illness, the medical problems, the economic stress that so many people are suffering. These are all extremely stressful life events potentially, and cultural events that can combine to really create kind of a crisis in the topic of mental health and suicide. So I want to talk about a little bit about some research that talks about suicide in the healthcare professionals. This is some research that specifically focuses on physicians, but I would argue that most of these factors mentioned in this particular research really overlaps with scientists and biomedical researchers in the same way. There really are higher suicide rates in physicians than other professions. It's stigmatized and it's kept quiet. So you are not necessarily hearing about this, but that it does tend to be a statistic that physicians are more likely to commit suicide than other professions. And we talk about that not to scare people or not to create too much alarm, but we talk about it because we want to try to get to these reasons that were cited in the research. Personality factors is just the perfectionism, tendency toward anxiety, tendency toward being very high functioning and having high career stress. Contagion is something that happens within a small community. Suicide can be and is known to be contagious. We'll talk about that later in the presentation. But the extreme amount of stress seen in research and scientific communities, the idea that scientists and physicians see themselves as problem solvers, not people who have problems, right? But people who solve problems. That identity of solving problems and not having problems oftentimes makes it really hard for people in the research community to feel comfortable speaking up and asking for help when they do have a problem. Isolation, the research just talks about the intense study pressures and the intense workload and the intense publication pressure, and all of that combining to giving someone a feeling of being alone and isolated, especially if they are in a professional environment where they don't feel comfortable talking about what they're struggling with. So if this is a problem, suicide is such a problem in healthcare and scientific professions, the question is, what can we do about it? How can we lower the suicide rates? And it's really what we're doing right now. I mean, we're hoping to create a larger cultural shift in the field where there's early education about self-care, an emphasis on self-care at all, a focus on wellness, suicide prevention education, of course, just talking about empowering people to feel more comfortable, having the conversation, stigma reduction, and normalization of help offering connectedness, and working environment. So it's important to talk a little bit about racial disparities, because it is true that research tends to show a higher incidence of suicide completion in whites as compared to people of color, except for American Indians, who tend to have a very high documented suicide rate. It's important that we know this isn't just a white problem, as sometimes it's misconceived to be. There's a couple reasons why we think there is higher rates of suicide in the white populations versus people of color. And one is just misclassification. I've read a lot of interesting research on how, you know, the authorities who classify mysterious deaths, where it could be classified as an accident or a homicide. When we see similar circumstances for a white individual and a person of color, authorities are more likely to classify it as an act of violence, like homicide, rather than suicide. So we think there is a real problem with miscalculation based on systemic racism. But we also think that some of the belief systems and religious beliefs sometimes likely to be a more important part of the culture for people of color can be a bit of a protective barrier against suicide. It also, though, contributes to the misclassification, because people of color are less likely to gain official mental health resources, right? And when it's not documented, then it's less likely that a person will be found to have committed suicide when authorities look at trying to assign a label. So the take-home message is that we have to be alert to the development of culturally sensitive interventions. And I want to focus again on the idea that that is why, another reason why we can't really afford to have this conversation limited to mental health professionals. Because if we do, we are going to be missing so many populations that might have been willing to talk about their suicidal ideation with a trusted colleague, but are not inclined to seek mental health resources for various reasons. So we have to really work on opening this conversation, broadening the spaces where we talk about this difficult topic. The LGBTQ community is a group that tends to have much higher rates of suicidal ideation, and we can typically attribute that to really the isolation. LGBTQ youth in particular are almost 5 times as likely to have attempted suicide as compared to their peers. We see this trend higher in individuals who come from highly rejecting families, right? We see that isolation and shame. And this is true at campuses too. Suicidal ideation is higher on campuses that have less support. And I want to tell everybody about the Trevor Project, which is a really interesting group that focuses specifically on offering help, mental health help, and sort of a 24-hour lifeline specifically to LGBTQ communities. There's also a lifeline specifically for trans populations. So these are all really good resources to have on hand. A big part of our talk today will be about how you, if you ask the suicide question, can then make the connection. These are going to be some great resources for you to connect individuals to, for them to seek more help. Suicidal ideation, again, is that thought of thinking about killing yourself. So it's important to not panic. If a colleague thinks about, mentions killing themselves or is thinking about it, it's important to stay calm and move through the stages of helping them that we will talk about. So again, another key point, talking to someone about their suicidal ideations does not make them more likely to commit suicide. This is a really common inaccurate belief that we hear in this field. It doesn't make it more likely that someone will commit suicide. If we mention it, it actually makes it less likely. Okay, so now let's talk about how you can help a colleague who is in emotional pain. Think about this as sort of a 5-step action plan. You're asking, we're going to talk a lot today about learning how to be a little more comfortable with asking the question, keeping them safe by reducing access to lethal means, or just connecting them immediately to a mental health professional. Keep the National Suicide Prevention Lifeline number with you. Keep it on you. Keep it in your phone. Keep it in your office. Have it available so that you can give it out to people. Just being able to make that connection can save a life. And then stay connected and try to stay in touch if you can with a colleague with whom you might have a serious conversation about suicide. All of these interventions here are the brief interventions that we talk about: asking, making a connection, listening. These are all things that can reduce suicidality. So we want to talk about how to help you feel a little bit more comfortable with this. I want to emphasize that this might not be ever extremely comfortable, right? It's not comfortable for a lot of us, but it's still something that can be manageable. So the most important question, if you are in a conversation with a colleague who is really opening up about something that they're really struggling with, and you are getting signs that they might be suicidal, it's important to just ask the question. Ask it after you have enough information to reasonably believe the person is suicidal. We will get to more examples of how to do that. Don't ask as if you are looking for a no answer. Again, it's not an easy question, but research shows asking at-risk individuals if they are suicidal does not increase suicidal thoughts. It only can reduce them. So try to remain calm, try to have an open conversation. Listen more than you speak. If you encounter a colleague who is feeling suicidal, you are not going to try to solve their problem. You are just going to try to get a feeling for if they are suicidal, maybe learn a little bit more, and then connect them to a professional. You can use supportive and encouraging comments. You're not trying to solve their problem if you find yourself in this situation. You're just trying to help them make connections to a professional or keep them safe. Okay, so listening to your colleague. Listen carefully. Again, research suggests acknowledging and talking about suicide may reduce it rather than increase it. So try to let the person finish whatever their given thought is. Use phrases to keep the person talking. You can attempt to rephrase what the person is saying to ensure you understand. Use eye contact and body language. This is sort of the be there part of the 5-step process. Just being there for someone who's in a lot of emotional pain is effective. You don't have to say much beyond listening and paying attention and trying to be supportive. So we want to talk about some real specific directions on what you can do if you are in this spot, right? We want to give you specific statements that you can say verbatim to a colleague who is struggling. So this is sort of an if then when to decide to ask, because you don't want to ask out of nowhere. You want to have reasonable assumptions, reasonable belief to assume that the person might be feeling this way. And the way you do that is if you're talking to someone about something that's going on in the lab or professionally, you can ask an open-ended question like, tell me more about how you are doing. Now there's general venting where a person is frustrated, but they clearly have some support. They have some coping mechanisms. They're still showing up to lab or showing up to the office. They're mostly doing what they need to do, but they're struggling. And then we have some of these real red flag trigger statements that tell us it might be a good time to ask the suicide question. These people who have these red flags are starting to feel hopeless. They're kind of giving up. They don't have any support. They're isolated and they feel like there's no option. So these are 2 paths. You can still listen, validate, support, and refer to someone who has a problem. But if you are hearing these statements of nothing is worth it, I don't have anyone to turn to, I can't get up in the morning, then you're starting to think, I wonder if this is an appropriate situation in which to ask. These are specific sentences that you can use to ask this question because we found that this is so uncomfortable for people. I want you to know that it doesn't need to sound natural. If it sounds a little bit robotic, but you're still asking the question, it can still really help someone. So these are different ways you can ask the question. These are different examples The important thing is to not sort of minimize what you're asking. That's the key here. A lot of people will say something like, are you thinking about hurting yourself? It's a little easier to ask that, but hurting yourself is really not the same as wanting to kill yourself. Many people struggle with self-harm, or that's a coping mechanism that they have, and that does not mean that they want to die. So we really want to ask people directly. Research shows that if we ask directly and plainly about suicide, killing yourself, ending your life, that we are more likely to have an impact. So if we get a no, the worst that can really happen generally is someone might say, no, of course not, I would never do that. It might be a little awkward, but you can just say, okay, well, I'm glad to hear that. Let's talk about resources. Try to have these resources on hand that you can help connect people with. If they say yes, take a beat. Say thank you for your honesty. That's a good thing to say when someone says yes. A lot of people say, oh, I would have no idea what to say. You know, if someone says yes, they want to kill themselves, it's scary. It is. But thank them for their honesty, because that's what's really important. They're now revealing something, and now you can help them to get help. This is a problem that not only can you not solve on your own, but you can't manage it on your own. If someone in the lab or in your office is saying, yes, I do feel suicidal. So you say, let's keep talking about this and try to help you feel better. And then you move on to sort of making the connections. Now, if we move back here, if you get a yes, you can immediately go to calling the program within your institution that offers support, making a connection to a mental health resource. But if you are comfortable and you are in a position to delve a little deeper, then you can ask a little more and assess for suicidal plans. And that gives us a better idea of how serious it is and whether or not it's an immediate threat. So plan is a huge part of suicidal threat. If someone has a plan on how they're going to kill themselves, they're much likely to follow through with it. We know that from research. So if they say no, I'm glad to hear that. I think if we helped you feel less miserable, you might not consider suicide. And then we can try to connect them with someone. If they say yes and they have a plan, now you know that the risk is raised a little bit, and you need to connect them to somebody immediately. You need to connect them to somebody who can keep them safe. You want to make sure that they are either going to you're going to walk with them to an office at your institution who can help them with a counselor, or you can ensure that they go to the nearest hospital. So this is how you assess how serious a risk is. So if someone says yes, and you want to find out if it's an immediate threat, or yes, I've thought about it, but I'm not going to do it. It's crossed my mind. You ask if they have a plan, because a plan tells us the person is much more likely to do it. You have a plan for how you would do it, and do you think you're going to do it now? Do you have the means? Is there someone in your life that we can reach out to for help? Is something you can do to make a connection? Are drugs and alcohol playing any role in your life? Research shows us that alcohol and drugs are frequently involved in cases where people commit complete suicide. And then have you ever tried killing yourself in the past? Because that's a really significant indicator that someone will attempt suicide as if they've attempted in the past. So how do we respond to the risk? As we've discussed, there's different levels of risk. If someone says yes, there's sort of moderate and high risk. These are steps that you can take to help someone who is in your office. You've asked them the suicide question, and they've indicated that yes, this is something they might be at risk for. You can say right then and there, let's call the EAP center together right now. Who in your life can we call for some help? If this person lives with someone, has a roommate, has family members that live close by, you can call them together so that someone else in their life is aware. Would it be helpful to have a referral for a counselor in the area? Definitely the suicide hotline number can be given to them. And then let's walk over together to talk with someone and get some help if there's someone in your institution that can be helpful. High risk is when they have a plan. They tell you they are potentially going to carry out the plan. They're thinking of carrying out the plan, and they have the means for the plan. Then you know they at higher risk. So these are the risks and protective measures to give you a little bit better of an idea of what we tend to see in high risk groups of people who are suicidal. Hopelessness, helplessness, a major depressive episode, the impulsive behavior, the agitation, method for suicide is available. Means is actually a really important part of assessing suicidal ideation. While asking about suicide does not make people more likely to complete suicide, having the method and means closely available, having a huge amount of prescription medication on hand, having a gun is a really, it's the most common way people die from suicide in our country is from a gun, but having those means available does make it more likely that someone will complete a suicide attempt. And then the protective factors are the person identifies reasons for living, feels responsibility, has a supportive network, is engaged in work or school, and even that they believe that suicide is wrong or immoral. So if you are at the point where you are talking with someone, again, and you are trying to help keep them safe, then giving them, as you make connections to other professionals that can help them, you can also talk to them about means, because like I said, means is a really big deal. Keeping people protected from means is a good way to lower suicide risks. So as you help them make connections, if you are comfortable having a longer conversation about their intent, you can talk to them about medication, never keeping lethal doses on hand, keeping it locked up. Like I said, firearms, the most common way people die of suicide in our country. So keeping them locked and safe is important if somebody is having suicidal ideation at all. And it can be very beneficial to talk to them about firearms. So disabling the lethal means can make a big difference. So if you end up having a conversation like this with someone and you connect them to support, try to follow up with the person, try to follow up in a week or two and have that conversation after you've connected them to the resources. Again, research shows that if you bring them back into your office or you see them in the lab and you are able to ask, how are they doing? How are they feeling? Open-ended questions. It only serves to sort of reduce the stigma associated, because we want people to be more open to telling us that they might be suicidal. We want to enforce the idea that it doesn't have to be surrounded with shame and stigma. So resources, save in your phone. The Suicide Prevention Lifeline is something I give to people all the time, send to people now electronically. I know a lot of people who have used it, some with different levels of help, but it's an option. And I've had a lot of people call and get a lot of help. It's something, we just want to help people connect, help people make a connection with a trusted individual and their family member, a spiritual advisor, a mental health professional. Another important take-home point is this isn't something we can start alone, the conversation about suicide, but ultimately the more resources that we can give an individual, sending them to seek some kind of mental health assistance is going to increase the likelihood that we can lower those rates. So a little bit more about risk and response, just to give you an idea of what low suicide, moderate suicide, and high suicide risk looks like. Low suicide risk is someone who's wishing to die or has suicidal ideation, but without the plan. If someone says yes, but they've never thought about how they would do it, much less likely that they are someone who's an immediate threat. Use the 5-step action plan, make a mental health referral, and follow up. If someone's a moderate suicide risk, it's that they have many risk factors. They don't have a plan, but they have, they have thought about it in the past month. And then the high risk is people with intent in the past month have thought about it and have had some behavior. So if somebody is telling you, yes, this is how I would do it, I have the plan, I have the gun at home, I have the pills at home, then your action is to stay with them and help initiate a campus authority connection or a hospital connection if they are an immediate threat. So what we'd like to do now is show you some examples of what this might look like in your office or in your lab. We have actors who are NIH professionals. A little disclaimer, this is not based on specific client cases, and the people in this video are not having mental health disturbance. This is just acting for the sake of us demonstrating what this might look like for you.
I wanted to check in and see what's happening for you.
It's not been great lately. Not great.
Not great. What's going on? Can you tell me a little bit more?
Yeah, I'm feeling this way for a while now, but I'm not sure that graduate school is for me. I mean, I just don't know that this is gonna work out for me.
Ooh, that's hard, huh?
Yeah, it is hard, especially when everyone else seems to be progressing and moving along. And, you know, I look around me and I'm the only one that's kind of standing still. I feel like that's a pretty clear sign.
You know, graduate school for everyone has its ups and downs and its low points. And one of the things is to be careful about taking care of yourself. I wonder what you're doing to take care of yourself.
You know, it's funny that you mentioned that, because I was just thinking, I used to go for hikes and that felt really good to me, but I can't seem to even do that. I can't remember the last time I went for a hike. And you know, I would go with my friends, but I really haven't seen anyone lately. I mean, I used to, you know, at least see people in lab, but I mean, to be honest with you, I'm kind of feel weird admitting this, but I haven't been to the lab very much. I try to sort of go and sneak out a little early because it feels like, what's the point of being there? And then when I'm at home, I tell myself I'll work, but then I watch Netflix, and sometimes I'll drink while I'm watching Netflix, and then I really can't work. So I guess not much to answer your question.
It seems like things have really taken a turn for you lately. Is that true? That you're feeling worse now than in the past?
Yeah, I mean, I guess I didn't realize it until I said it all together, but I guess, yeah, things have gotten kind of dark, kind of not so good.
You know, it's hard for me to ask, but I think it's important and I care about you. I just, I'm wondering if you've been thinking about killing yourself.
Yeah, I mean, yeah, it crosses my mind. Yeah, it crosses my mind, I guess. Yeah.
First of all, I want to thank you for being honest with me. You know, I want to keep you safe, and suicide is a really big issue for anyone to handle alone. And so I need to reach out to some mental health experts to give me some guidance in helping you take care of yourself. Would you be okay if you and I reached out now to someone in student services in the counseling center who's trained and can help you access additional resources?
Yeah, I mean, I don't really want to bother you if you're busy. I don't really want to bother you, but I mean, maybe it's a good idea.
You know, it's not a bother, and right now the most important thing is your safety. And so if we could just take a few minutes and make that connection now, I think it would be really great. Thank you for being open to that.
Okay. Oh, okay.
Okay, so what I'm hoping that you noticed there was that the questioner was talking to their colleague, and we saw the red flags, right, that we had talked about. The person was isolated. They said, I'm not really going for hikes anymore. So they're not doing things that they used to enjoy. They're not able to go to work. So they're not just struggling with work. She said she wasn't really able to go into the lab. She said she was drinking. So now we have substances thrown into the mix. And then you can see how the questioner said, this isn't easy to ask, but I want to ask you the question about suicide, because there were some real red flags popping up in that conversation. After the questioner asked and the person said yes, they thanked them for their honesty. And then they made the connection to an institution or a counseling, the office, to help them get help for their problem. So the next segment is similar. It's a sort of hypothetical, not based on a specific client. And it is an example of a person who is even a higher threat, and the questioner determines that they're at a higher threat because the questioner is comfortable sort of asking about means. And they determine there's a red flag, they ask the question, they determine that the person has the means to commit suicide. And then this is what you can do if the person does not want to take the help and is sort of refusing to take help.
Maureen, you want me to just do the last one, right?
I thought we were going to do the middle one.
The middle, okay.
Sorry. There. A little further.
Yeah. I've noticed lately that you seem pretty down. You're not around a lot. I just feel that you aren't quite as connected here at work, and I was wanting to ask how you were doing.
Yeah, I haven't felt very connected. I didn't get into the program, and it's just like I'm realizing that this isn't the place for me. This isn't the direction for me. I don't belong. It's not for me.
Yeah, that sounds disappointing about the not getting into the program, but also scary in terms of, not feeling that this is the right thing. Have you given a lot of thought to other possibilities in the future?
There aren't. I mean, this was it. This was like what I worked for my whole life. Since I was a little kid, this is what I wanted. And, without it, like it just like, there's nothing to look forward to. There's like, there's nothing else.
It's awkward sometimes to say this out loud. But I care about you, and I really need to ask. Are you thinking about killing yourself?
Yeah, I've been thinking about it.
Thank you for being honest. Have you given a lot of thought about how you might do that?
Yeah, I have.
And what have you been considering?
With all I've been struggling with, I have a regular pharmacy in my medicine cabinet, prescribed pills and over-the-counter stuff, and I think, yeah.
Have you ever tried in the past?
Yeah, I did once, but it wasn't enough. It just made me sick. So, but I've got a lot more pills and a lot now.
I feel I feel like it's really important for us to work together right now to keep you safe. I wonder if you would be open to reaching out now together. I can sit with you until you make a connection, reaching out to someone that you can talk with about these really hard feelings.
You know, I don't know. I don't know if it would help. I don't know that anything would help. You know, but
Well, I really care about you. I would appreciate if we could make that connection. Well, I can't promise anything about what might or might not help. I do know that talking with an expert about this right now is really important. And so if you're okay with it, I would like, I'm going to make a call right now to the Employee Assistance Program here and find someone who can talk with you. I'll even walk you over if they, if you'd like.
okay, yeah, okay.
Thank you. So why don't you, let's just stay right here and I'll get the number and we'll take care of that right now. I want to thank you for being willing to follow through with me on this call.
Okay.
I want to thank you, Annie, for being honest with me about all of the things going on for you and your talk about suicide. And I wonder if you'd be willing now to call the Employee Assistance Program right here from my office. I can make sure you have a connection with them.
No, I don't think so, no.
You know, I think this is a really important thing. Right? Your safety matters, right? And you matter. And I'd like to ask you to reconsider that. And you can just, in fact, I can make the call for you and just hand over the phone and then you can talk with them in private. Would you reconsider and do that?
No, I don't want you to do that, no.
Is there a healthcare provider that you know that would feel more comfortable to you that you could call instead?
No. No.
You know, Annie, I think I'm going to have to go ahead and call the Employee Assistance Program now to talk with them about it. My ultimate goal is to keep you safe right now, and I'm really afraid that you're in a tough place. And so while I appreciate your wish that I not do this, I'm going to move forward.
I really would rather you, I don't want you to do that.
I understand that. And hopefully someday in the future we can sit and talk through what happened today, but I'm going to make that call now. Hey, Lori, how are you?
Okay. All right. So I hope that that was kind of helpful in seeing what this can look like in practice, right? That was an example of a questioner and their colleague. We saw two different scenarios. In that last clip, we saw the scenario where the questioner was comfortable asking a little bit more about means and getting a picture for how immediate this threat was, and then pursuing making the connection to get further help. And then we saw an example where the person was refusing, and that might happen. But we can't tell you to ask this very difficult question without then knowing how to follow up. And if the person refuses to get help, but they have revealed to you that they have lots of signs of being an immediate suicide threat, then we have to make the connection for them. And we hope that the connection can be something like walking over to the EAP program together or calling together. We hope that can be the first step because it isn't likely to create a lot of shame and a lot of attention. But if you are in a situation where the person is refusing any of that and they are at risk, and you can tell they're at risk because you've asked about means, then you have to consider calling 911. Of course, that's the option, but it's very possible to help someone who's a suicidal threat without resorting to calling 911 and having an ambulance come. So you want to try to do that, and you're not always going to be able to if you end up in this situation. So just wrapping up a little bit about the topic of suicide contagion, I want to talk a little bit about it because it is something that research has been shown to be a real phenomenon, that when suicide occurs within a given community, the smaller, the more enmeshed and connected the community, and the more highly publicized the suicide is, the more likely we are to see copycat suicides, it's termed, or other suicides by similar means. This effect is strongest in the adolescent population, but it's also higher in any population where people are really interconnected and know each other and know a lot about each other. And that's why I mentioned it in the slide on physician and scientist suicide. The effect is highest when the community is really saturated with reports of the suicide and it's really, really publicized. And this kind of complicated dynamic of suicide contagion and what we have to do at an institution or in a community to reduce it can impact why people are really confused on whether or not this is really happening or whether or not it's a problem, right? Because in order to mitigate the effects of the suicide contagion, we sometimes, communities have to make decisions to limit reporting, and that can really complicate the shame and the guilt surrounding a suicide. So I want to talk a little bit about how we can manage that and how we can stop or slow down the effect of suicide contagion within a given community or at a given institution, while still giving community members the opportunity to grieve and come together. So the way that can be done is to limit the volume of reporting on a suicide, limit reporting of means. If someone commits suicide within your institution or within your professional community, it really isn't important to talk about means or method. It's important to not attribute simple explanations for suicide or reasons. The reasons are complicated and difficult to ever really pinpoint anyways. Be careful not to glamorize suicide. 13 Reasons Why is a TV show that affected more adolescent populations a few years ago, but research showed that there was a real increase in numbers of suicide because the character was sort of portrayed as somebody who sent everybody a lesson about how that the person had been treated. And it did have an effect of glamorizing suicide in a way that really led to contagion. In any reporting or discussion of suicide, include that suicide prevention lifeline number and talk about coping skills, talk about support, and talk about ways that suicide can be avoided. So it's a tricky topic to help a community grieve while not increasing suicide contagion. But if it's done appropriately, people can grieve while also recognizing that there is another way. There are alternate paths to coping with a problem. So lastly, I want to give you a connection to some resources here that you can utilize, books, websites. There's lots of good resources out there. These are some that I find particularly helpful. And I think I'll open it back up to Sharon.
Great, thanks, Maureen. So I'm going to start just with a comment, but there are several questions around it. And this is coming, all the scenarios we're playing, and it is a little far-fetched. People really don't, have conversations like this. people wouldn't say. I wonder if you can just talk a little bit about how far-fetched you thought that was, and what a conversation really might look like.
Is that for me or for?
Yeah, for you.
I don't think it needs to be far-fetched at all. I mean, I think that as we think about checking in with each other at all different levels of a professional institution, I think that if somebody is really isolated, you have to recognize that if someone is far away from their family, working alone from home, struggling with their career and doesn't have anyone around, it isn't so far-fetched that a colleague might be the only person that someone has to talk to. It's not true for most of us, hopefully, that we have other people we would talk to, but I think the idea that someone would never talk to a colleague about something like this is, I don't think it's far-fetched, and I think it's something that for some people, this is their only opportunity to connect with anybody and to open up.
Thank you. I guess I'll add, as somebody who's been doing STEM education for a long time, I have had conversations like that with students. Glad that I was willing to ask, because people have shared that they were considering suicide, and to me that was a chance to step in and help. So they didn't feel far-fetched, but given that there were multiple comments about that, I thought we should start. And I guess I'll acknowledge no role play is perfect. This would have played out probably in a much longer conversation. But for teaching purposes, if it felt a little far-fetched, I guess we acknowledge that. But the basis of these role plays are rooted in situations that many of us have dealt with. And I'm not a mental health provider. I'm a scientist by training. There are several questions about doing this virtually. That even though we were making the tape virtually, the responses were as if we were together. I'm going to stay here with you. And whether you have advice now that we're all living in this virtual world for how people can stay with someone and keep them safe virtually.
Sure, I think that a very similar conversation with very similar techniques and connections can be done virtually. That is the world that we are living in right now. So I think that all the interventions used, asking a person virtually can be done, and saying, you know, while we're on this Zoom call, can you pick up your phone right now and call the suicide hotline number? And I'm just going to kind of let you make that connection right now, can happen. Or, you know what, while we're on this Zoom call right now, can you pick up your phone and call this counseling center right now? Or why don't you reach out? Why don't we, I'm going to sit here while you go get your roommate. You know, can you trust your roommate? Can you go tell your roommate that you're going through this and they can help you? All of that can happen virtually. And kind of right now, we have to open it up to the chance that it will happen virtually, right? Because that's how we're having so many of our communications, and it can still be useful and function in a similar capacity.
There's a question about the suicide hotline. Somebody said that a friend of theirs needed to call one recently, and they were on hold for hours. And what other alternatives are there?
I'm sorry to hear that. That just hits home the point, you know, that our mental health resources are really being overwhelmed right now. You know, sometimes going to the local emergency room if somebody is in a really rough position and is an imminent threat can be the best resource. There's also different suicide hotlines, and some of those are listed in the resources. That's the primary one, but there's other resources and subgroups.
Thank you. You've talked about suicide being stigmatized and kept quiet among medical professionals, but also that reporting and talking about suicide can contribute to suicide contagion. So there's like this balance of needing to talk about it, but not wanting to drive contagion. And the questioner asks if you talk a little bit about how to navigate those two different sides of the coin.
Yeah, absolutely. It is tricky. I think that when reporting goes wrong is when there's a lot of reporting, irresponsible reporting, meaning reporting without offering the resources. Something that research has found over and over is that effective suicide contagion mitigation means that it's not that you don't talk about it, but you talk about it with advice for someone who is struggling with it. And less responsible reporting can just be over and over talking about the person who killed themselves sort of without an answer for how to cope with it. So that's one thing. Also, there's a difference between publicly reporting repeatedly to a community and offering ways for people to meet in small groups or individually to talk about their grief, and being okay with talking about grief on a smaller scale. But it is tricky.
Great, thank you. So in the second video, I think that was probably the one with me and Annie. What did you see as the red flags indicating a potential suicide? The person says, well, plenty to be concerned about, but wouldn't necessarily have seen it as a suicide threat.
Right, and I think knowing exactly when to ask the question isn't as important as practicing asking the question. The person had a major loss of, Annie in that scenario, you know, a loss of professional meaning. That could be a real major triggering event. Feeling like that she was hopeless and didn't really have a route to go. But I would say, when in doubt, you can always say, I know this might be totally wrong. This might feel a little awkward, but have you thought of killing yourself? It's better to ask in a situation where it might not be warranted, I think, and to cope with someone saying, no, of course not, I would never do that. But I think that whenever we see a lot of hopelessness or real frustration at the course of someone's life, feeling like they don't have an answer, feeling like they don't have a path, that is what is a kind of a red flag that stands out.
Can you address a little bit some language? I've heard, this is what the questioner says, I've heard that saying taking their own life or die by suicide is preferred over commit suicide.
Yeah, there's a lot of talk in the community, in the suicide prevention community right now, that commit brings up, you know, the idea that committing like a crime, committing suicide. So there's a preference moving towards taking own life and dying by suicide rather than commit for that reason.
I want to address the comment about the long wait on the crisis hotline. This is someone who is now volunteering for the crisis text line, and they reported that there's been a dramatic increase in the number of volunteers to reduce the wait times. So just an important piece of information about that. Somebody said, has a question about if you can't get help immediately, is it appropriate to ask them not to act on their ideations in the moment? So this person says they had a colleague talk about cutting themselves, and they asked that person to promise they wouldn't do it before talking again. And it worked in that case. And is this a reasonable strategy in general if you can't get help to say, can you promise me not to do that till we meet again?
Therapists use that technique sometimes to, you know, various beliefs, sort of philosophical beliefs on whether that works. I think that it's always a good therapeutic technique to, if you can get someone to think in terms of, I'm not going to make this step today, and I'll reevaluate it maybe tomorrow or next week. I think that's something that can be very useful, especially if you're in a situation where you don't have any resources to connect a person to. I mean, that's sort of like a riskier step that is more likely to be used by a mental health professional, and it's controversial, but I can say that that is something that can certainly be helpful if you can't make the connection. That it's not always going to work, but there are definitely times in which that feeling of I'm just not going to do it for today gives people a sense that they can hold on for another day. It's easier to hold on for a day or a week than it is if you feel like you have to keep living this way for forever.
I'm going to try to put together a few questions in one last one. There's some concern about the escalation of calling help, whether it be someone on campus or the police or one of the crisis hotlines, that if you do that, then it escalates the situation, which might keep somebody from, being open and honest the next time, or can lead to all kinds of sort of consequences of making a report.
That's a systemic issue, right? That's sort of like, how do we make it that it's okay to seek help? That it's okay to seek help without being punished or shamed within your professional community. How do we do that is a larger question that I think has to happen at an institutional level, because it's a real concern. People are absolutely afraid in all kinds of different working environments, right? That if they reach out for help and someone finds out that they were feeling suicidal, that they will be shamed or, lose their job. And that's a contributor to people living in isolation.
Yeah. I know I said last question, but I'm going to ask one more. It's from someone who recently lost a colleague to suicide. And many people who knew this colleague talked about how they didn't really show any signs, and sort of what you recommend in that case.
Well, the thing that we have to remember in that case is that we can't prevent every suicide, of course, nor are we, attempting to. There will absolutely be cases where someone will not tell a soul, will not hint at all. And it's tragic. And it also tells me the intent to which, either that they've never felt comfortable talking about it at all, or that they were really intent to die. So wrapping our minds around the idea, that's hard to wrap our mind around, that we're not going to be able to catch every person at all. It doesn't mean we shouldn't try to help some.
Thank you. There are some questions in the chat about if people were less calm than the role plays, and I think we'll leave those for the small group discussions. So everybody, let me just give you some. First, let me thank Marin for talking about a
Thank you.
important topic, and all of you for coming and asking important questions and having this discussion. We're going to take a short break. We're going to start promptly at 2:15, but you need to switch from Zoom webinar to Zoom meeting. The meeting ID is 161-301-5107. The passcode is 582089. It's in the same email where you got the initial link for this, and you'll join at 2:15 or earlier if you're ready. And then we're going to get into small groups and be able to keep having more Q&A and actually some exercises and debrief. I want to thank everyone for being here, and we'll see you on the other Zoom call in a few minutes. Thank you.